Hi guys, we're back again with another session. This is session 14 and this is going to be about enteral and parenteral nutrition, dysphagia, and aspiration pneumonia. Just take a look at this first picture. Here is Tim thinking about what? A juicy hamburger, but that's far from what's on the doctor's mind. She's saying to him, Tim, I'm going to give you tube feedings. He's not really in line with that, but it's not really a choice. Later on, we will discuss what causes people to have tube feedings. There are very many different types of tube feedings on the market, so whatever is ordered is entirely up to the doctor. Some have fiber, some don't. The doctor decides what's best for nutrition's sake. Different types of tubes, and we don't have time to go into all the different types of tubes. We have nasogastric tubes, some of those tubes that are inserted from the nose into the stomach. We have some tubes that are inserted from the stomach into the stomach. That's done in surgery usually. And then sometimes we have tubes that go past the stomach. Even though it's introduced into the stomach, it goes past the stomach into the jejunum if the doctor wants to keep the stomach empty for whatever reason. And so we're going to discuss a little bit more about the causes of what could possibly happen to make a patient have to get a feeding tube. Well, let's take the case. The causes would be, the main cause would be dysphagia, and what it means is difficulty swallowing. We find dysphagia in patients who have had things like trauma, a stroke, sometimes things like esophageal cancer. There are many causes, multiple sclerosis, and there are many, many more why patients can possibly have trouble swallowing. Now, there are some tubes that are put in for only short term, which we will discuss in a minute, and then you have those which are put in for a long term, which is often referred to as a PEG, P-E-G, which means percutaneous endoscopic gastrostomy. Nutrition has to be given to patients whether or not they're on a ventilator. So in this case of this patient, he's on the ventilator, has to have nutrition, so he's going to have it via a tube. Then take the case of this other patient. She's had a stroke. You can see she's wheelchair bound, she's having difficulty. And the problem with patients who have had strokes, sometimes they have damage to those nerves in their brain called intracranial nerves, especially the 9th and the 10th, which deals with gagging and swallowing. Some people can swallow their food, but then it goes down the wrong way. And sometimes they cough and choke on almost anything. So after a swallowing evaluation, usually the doctor decides to put them on tube feedings. Let's take the case of Mary here. Mary has a nasogastric tube, as you can see. If you look behind her, you'll see she has tube feeding, but notice it has been stopped. Reason being, Mary is going to go to the OR. She has tube feeding, but this is only a temporary type of tube. You cannot leave a nasogastric tube in for too long because it will do damage to the cartilage around the nose. So what happens is she's going to have what is called a PEG inserted into her stomach, which can be used for long-term use. In the meantime, bear in mind, if you have a patient who's been having tube feedings and is scheduled for OR the next day, generally the doctor stops them having fluids at midnight. You cannot just leave them to get dehydrated. The doctor usually writes an order to continue IV fluids throughout the night until they get rehydrated again with their old nourishment. So if you have a patient who's been ordered for the OR, stop the tube feedings at midnight to keep the stomach empty, and no tube feedings or no other fluids are ordered, then you should take it upon yourself to call the doctor to find out what needs to be done. And of course, like we say, we're going to talk a little about aspiration pneumonia. When patients have nasogastric tube feeding, there is a danger of aspiration. This should always be in the front of your mind because it can happen. If you lower the head of that patient, it doesn't have to be you. Visitors can do it. I've seen that happen, where someone came to visit and lowered the head of the bed, and that poor patient aspirated. You need to warn your visitors, do not lower the head of the bed without permission. Head of bed is usually kept up 30 degrees. Usually the doctor writes orders to check the residuals. There's that special syringe that you use to draw back. If your residuals are very high, the doctor usually lets you know what's acceptable, maybe more than 200 cc's residuals, stop the tube feeding and continue whatever his orders tells you to do. But it's very important to check residuals and not just continue to give tube feedings without paying attention to what's happening, because the stomach can be filling up. Another thing is you check for bowel sounds. If there are no bowel sounds, then you need to find out why. Large residuals, no bowel sounds, that's not a good sign. So all of these things you need to be aware, assess, document, and let the doctor know what's going on. Abdominal distension is another sign that that feeding is not going the way it should be. Then we're going to talk about nutrition that's intended for another type, not this type. This is called parenteral nutrition. And what happens here, we have the patient who has parenteral nutrition for whatever reason, comatose patients, patients with bowel obstructions, peritonitis, and many more, why they cannot have feeding done through the tube. Take the case of Sheila. She's in a coma, so obviously she's not able to eat and drink. She is going to have what is called feeding, which is parenteral TPN through a central line. So this is in the chest. Sometimes they have what is called a PICC line, P-I-C-C, which is a peripheral line that goes through one of the main vessels here in the arm, at that on the inside here of the forearm. And usually those last for a very long time, but it's up to the doctor to decide what he wants to do. TPN, there are some things that we need to learn about it. It's infused with a filter, because if you don't put that filter, it's not going to work. It's usually a sterile solution that's prepared by the pharmacy, and the filter is attached to the tubing. Usually the protocol says it's usually changed, I believe, every 24 hours, but you'd have to check it to be sure. Another thing you've got to be aware of, because of the large amounts of sugar, the blood sugar can get very high. So the doctor usually orders blood sugars to be checked every so many hours, and make sure. Some patients are even given insulin to bring that blood sugar under control. And then another thing about TPN, the patients who have TPN can have thrombosis. These are some of the complications, and because of the high levels of sugar, they're more prone to infections. Intralipids are also used along with TPN. These are fatty molecules that are added. This is all part of dietary. And usually what happens, the doctor has a nutritionist take a look at this patient and decides just how much nutrition is necessary for this patient. Another thing to be aware of, lab values are probably going to be done as well. So I hope you have learned something from enteral and parenteral nutrition. Have a great week. And stay posted for more clinical information.